welcome back to Bibliophile ASMR. It's your girl. So I got this idea for a video from one of you babes. It is to read from like some sort of medical literature. So today I have the 5-minute clinical consult 2016. Tomorrow I have a physical exam I have to do at 1:30. I'm getting my tongue checked out at 8:30 a.m. I don't know if I bit it or what. Yeah. But my dad did have cancer on his tongue, so makes me nervous. I want to start out by giving a couple of shout outs. Shout out to Crispy Tingles ASMR, my King Chris. Please go subscribe to his channel. He is an awesome ASMR artist and a good friend of mine. He definitely deserves more love. So please go and subscribe to his channel and leave him a comment in some videos and let him know that Bibliophile or Griffin sent you guys. Alright, so this is basically a book where each page is... Oh, I haven't seen this. Oh, wow. Oh, wow. Oh, wow. Okay. Oh, wow. There's just a bunch of flowcharts. I love flowcharts, but basically, each page flat is a diagnosis, and it will give you all the info on it. So let's go over some. I just did rheumatoid arthritis today in class, so why don't we go look at that? My tongue hurts so bad, it's so annoying. Let me read some of the things that I'm passing by. Retinal detachment, diabetic retinopathy, RH incompatibility, which is Rhesus incompatibility. Actually, let's read this. No, we won't. Yes, no, we will. So Rhesus, this is an antibody-mediated destruction of red blood cells that bear a Rhesus surface antigens in individuals who lack the antigens and have become iso-immunized to them. So this affects the hematologic system, the lymphatic system, and immunologic system. This is basically, in layman's terms, because a lot of this is going to be in like the medical terms. So this is basically your blood type is A or B or AB or O, and then positive or negative. If it's positive, that means it does have this antigen on it, Rhesus. With your blood cells, if you're A, let's say you're A positive, A means that your blood cells, your red blood cells, have an A antigen on it, like little spikes all over it. And because you have those spikes, our bodies don't want to attack those spikes. So, we don't have any antibodies to attack them. But we don't have B spikes on our red blood cells, so therefore we will have B antibodies. So patients who are A positive have both the A antigen and the Rhesus antigen, so the only antibody in their blood is B. So if you were to give an A positive patient any sort of B blood, you would have a reaction. Okay, and the same goes with B. If you're B positive, you are going to have B antigens and Rhesus antigens, so you're not going to have either of those antibodies, but you will have A. This is why O is special, and this is why don't have the Rhesus antibodies either. You are the universal acceptor. You can get A blood, you can get B blood, and either Rhesus positive or negative. Now O is special because it doesn't have A or B. So if you are O, you have A and B antibodies in your blood plasma. So what they do to make O the universal donor, because O has no spikes on it, they separate the red blood cells from the plasma, and the plasma is kind of the liquid the red blood cells are in. Okay, they'll separate the two. The plasma will have the A and B antibodies. The red blood cells will have nothing. So they will use these red blood cells and give them to A, to B, and to AB because they don't have any antigens for the antibodies to attack. Does that make sense? So Rhesus incompatibility is a disease that happens with mothers and fetuses where the mother is, let's say, AB negative. So therefore she will have the antibodies against Rhesus. Let's read. I'll explain it. Okay, so this is affects fetuses and neonates of childbearing females. So this is what happens. Circulating antibodies to Rhesus antigens are transferred through the placenta in the case of a fetus and newborn, and they attach to the Rhesus antigens on red blood cells. By the way, if I'm lisping, it's because of the tongue. Immune-mediated destruction of red blood cells leads to hemolysis, or the breakdown of red blood cells. Anemia, which is not enough transfer of oxygen, basically, and increased bilirubin production, which is a byproduct of the breakdown of red blood cells. This can also happen with the transfusion of Rh or Rhesus positive blood to Rhesus negative recipient. This is also what happens with maternal exposure to fetal Rhesus antigens, either antepartum or intrapartum. So let me try to write this down to explain it. Do I have a piece of paper? I'll use the back of this. Why am I going so in depth? I hope this is what you guys were wanting, because I can't do it any other way. This is how I am. So let's say the mom is A. Okay. Now we want it. She wants to be affected by the kid's Rhesus, so she doesn't have Rhesus. So let's say mom is A negative. And let's say the baby, through genetics, is A positive. I want to make sure you think you know it sometimes, and then you get worried that you don't know it, So I'm going to put these little A spikes all over. And I'm going to put little RH. Okay. And mom has just A spikes. Okay. And so mom, because she doesn't have the Rhesus spikes, she'll have the antibodies, which are these little Y-shaped things. So we'll put the little Y-shaped things. She will have both B and Rhesus antibodies, whereas fetus will just have the B antibodies. Okay? Are you following? Are you taking notes? There's going to be a quiz. Okay. This might be backwards. Okay. So we have mom with A negative. She has the A spikes. And because she doesn't have B spikes, she has B antibodies and Rh antibodies because she also doesn't have the Rhesus antigens. Over in fetus, the fetus has Rh spikes and A spikes, so therefore the only antibodies the fetus will have is B. So what happens is, let's say this is mom's first pregnancy, okay? She has mom in this case. She will not have these normally. I forgot this, you only produce Rhesus antibodies if you have been exposed. This is why mother's first pregnancy with a fetus with RH is normal, because she doesn't have any antibodies yet against it. So this would be a depiction of mom's second pregnancy with an RH positive baby. I really hope I'm not confusing. I'm really trying to explain it. I'm sorry, this could be terrible. I've already made a mistake. But you know what? Even teachers make mistakes, so I'm normal. So, first pregnancy. Mom did not have these. Just these. Fetus was just like this. Well, what happens is these got through the placenta here, and mom's immune system was exposed to it. So mom started producing these, but by the time that she got enough of these, baby was already out. So everything's fine. Second pregnancy. This happens again. Baby has Rhesus, but now mom's body's prepared. So these red blood cells come through placenta, and these antibodies start attacking the red blood cells of the baby, and the baby can die. So it's scary. So what happens? This is in 15% of the white population and a smaller fraction of other races. Any Rh positive pregnancy in an Rh negative woman can result in sensitization. We talked about this. The risk. Okay, so then we use something called RhoGAM. So now we know mom's second baby's coming. And regardless if we know the blood type or not, we are going to give RhoGAM, which is basically giving, this is going to sound crazy, we are going to give mom antibodies to attack these antibodies so they cannot attack the red blood cells. So what would happen is these little connectors right here would connect right here, and they would attack. Basically, it's causing an attack. There's a lot of mechanisms, ways that they go about killing the red blood cells, but just know that they attach, and that basically leads to its demise. So what happens is we will give mom an antibody that will attach to this antibody, which is crazy in my opinion. Kind of like this. And it will connect, and then it won't be able to work anymore. So it won't attack baby. So it's RhoGAM. It's given to unsensitized Rh negative women after the following also. So this could be a first pregnancy too, if the mother's had a spontaneous abortion, an induced abortion, an ectopic pregnancy, an antepartum hemorrhage, trauma to the abdomen, an amniocentesis, chronic villus sampling, within 72 hours of delivery of an Rh positive infant, or routinely at 28 weeks of gestation. Okay? Prophylaxis is to prevent sensitization affecting a subsequent pregnancy, but has little effect on the current pregnancy. It basically would cause, if we couldn't treat this, it would cause hemolytic disease of the newborn. The baby would be born with jaundice, kernicterus, which is yellow in the eyes, fetal hydrops, or fetal death in utero if severe. So that's basically it. That's all you really need to know. You learned one thing already. It was probably really bad, so I'm really sorry. You can let me know if it was bad. We're passing rheumatic fever, allergic rhinitis, or the common allergy, Rocky Mountain spotted fever, roseola, rotator cuff impingement syndrome, not them not having rheumatoid arthritis in here. Okay, I guess they don't have rheumatoid arthritis, so we're not going to look at that. Let's see sarcoid, scabies, scarlet fever, schizophrenia, Schwartz syndrome, which is spinal cord injury without radiologic abnormality, scleritis, this is seen with rheumatoid arthritis and it can cause blindness, scleroderma, seasonal affective disorder. This actually, I believe, is not a diagnosis anymore, considered in the diagnostic manual. What do they call it? Like basically the psych textbook. Seizures. Why don't we go to depression or anxiety? My favorites. Maybe actually we won't, because sometimes they can be triggering and I don't want that to happen. Let's see if they have anemia of chronic disease. I love this disease. Okay. So this is called anemia of chronic disease, otherwise known as anemia of chronic inflammation. During a chronic systemic infection, inflammation, or malignancy, which is cancer, the production of pro-inflammatory mediators causes the inhibition of erythropoiesis, which is a term that means forming red blood cells, as well as the imbalance of iron homeostasis. Anemia of chronic disease is characterized as a normocytic, normochromic. Okay? Cytic means normal-sized red blood cells. Chromic means the color of the red blood cells, which is based on the hemoglobin, if I'm correct. Don't come at me if I'm not. But hematocrit. I hate being stupid. Normocytic, normochromic, hypoproliferative, meaning it's not producing enough anemia, and classically has low serum iron levels, elevated ferritin levels, and an elevated total iron binding capacity. This is the second most common anemia after iron deficiency anemia, due to the high rate of infectious diseases in developing countries, as well as the high rate of inflammatory and malignant disorders in developed countries. Okay. So, production of red blood cells is decreased due to a reduction in iron use and functional iron deficiency through the following mechanism below. Okay. So, pro-inflammatory cytokines such as interleukins, tumor necrosis factor, and interferons create changes in iron homeostasis in several ways. When you have inflammation, whether that's with an infection, with a chronic inflammatory disease, an autoimmune disease, or malignancy, your body produces these things, these little signals called cytokines that cause more inflammation. These cytokines will disrupt iron homeostasis. They diminish the proliferation as well as the differentiation of red blood cell progenitor cells. So there's a long pathway from original stem cell down to red blood cell, white blood cell, platelets, things like that. So it's saying that it diminishes the proliferation, meaning it expanding and making a ton of, as well as the differentiation, meaning from going from stem cell to red blood cell, it blocks these steps. It also diminishes the erythropoietin response. Erythropoietin is a hormone produced by the kidneys to produce more red blood cells, so it is blocking that response. And it also increases erythrocyte or red blood cell phagocytosis as well as apoptosis. Phagocytosis is when red blood cells are going to be sucked up by cells and killed, as well as what was the other word? Apoptosis. This is basically cell suicide. Cells will actually kill themselves. So remember when I was talking about the antibodies killing the red blood cells in our previous disease we were talking about? This is the way that they do it, through phagocytosis. So the antibodies are going to bind to the red blood cells and go to another cell, bind to it, and then it'll suck it up. Good to know. Okay, the production of interleukin-6, a pro-inflammatory cytokine, acts to increase the production of an iron-regulating hormone called hepcidin from the hepatocytes. Hepatocytes are liver cells. Hepcidin acts to decrease both iron absorption within the GI tract, as well as the release of iron from macrophages. Macrophages are a part of your immune system where iron is stored. Increased retention of iron within the reticuloendothelial cells also occurs. Endothelial cells are like the basement, like the endothelial. It's like the inner lining of red vasculature, but I think it can be really in any sort of endothelium, like any sort of lining of any tissue. Hepcidin accomplishes this by specifically negatively regulating ferroportin. Ferroportin is basically a hole in your GI tract and other cells where iron can get through. Did I just do that? Yes, I did. So, inflammation causes issues with the red blood cell formation, as well as iron issues. It works with this hepcidin, which then goes and fucks with ferroportin and the release of iron. So we have iron. Iron is being both eaten as well as stored in our body, but we can't effectively use it. So, because of that, okay, your diagnostic tests are going to show this. Low hemoglobin. Your cells are being made improperly, okay? So they have low hemoglobin, and hemoglobin needs an iron component. So because we're not able to use the iron we have, hemoglobin is not going to be enough. Hematocrit. It's also going to be low. Rarely less than 60% of baseline, unless in the presence of kidney failure. So it might be normal. No, it's normocytic, normochromic, so it is normal. MCV, which is mean corpuscular volume, which is the size of the cells, is usually normal, which is normocytic. And the red blood cell morphology, meaning its shape and size, is going to be normal. But this is where it gets interesting. You're going to know that the hemoglobin is low, so we're going to see on your regular a CBC, which is a complete blood count, we're going to see that your hemoglobin is low. And then we're going to get a possibly an iron level to see what's going on. Serum ferritin is elevated. Your stores of iron are elevated because we're not using them. Serum iron levels are low because it's being stored in this protein, which is ferritin, so the stores are high. But because we can't get them out, we can't pluck them out, the floating levels of iron are low. Total iron binding count is low as well because we have enough iron. Our body's saying we have enough, it's stored, but we can't use it. So our body says we don't need any more. Serum transferrin levels are also low. This is the transferrin is the transfer of the iron is low. And reticulocyte count, which is immature red blood cells, they are also low because, as we said, we're blocking that ability to go from stem cells to red blood cells. So this is a spectrum of causes. Okay. The symptoms resemble those of infection, inflammation, and malignancy that has caused it. Okay. It is often discovered incidentally on a routine CBC with differential, as I said. Okay. And then this is what we use to treat. Okay, we should obviously treat and address the cause. So either the inflammation, the infection, or the malignancy, we're going to treat that when anemia is due to inflammatory bowel disease, rheumatoid arthritis, hepatitis C, when chemotherapy in patients with a solid malignancy, and when you have chronic kidney disease with a GFR, which is the glomerular filtration rate, is less than 60 milliliters per minute, meaning the kidney is dying. Like we said, the kidney can't produce erythropoietin then. This drug can cause increased risk of cardiovascular complications and mortality in chronic kidney disease patients. It has the possibility of increased risk of thromboembolism or forming clots. It can possibly cause a rare red cell aplasia or issues with the red blood cells. And it can possibly cause an elevated risk of mortality with possible tumor progression in cancer patients. So, you really have to look at the patient's levels. You don't want to go over when the hemoglobin is 10. You don't want to use it if the hemoglobin is already 10. Okay, because then it can cause those side effects. You can also use darbepoetin A, which is, I think, another form of erythropoietin. You can give iron if the patient has a coexisting iron deficiency or is resistant to erythropoietin. It's more safe and it's inexpensive. You can give transfusions if the patient has ischemia, cardiac ischemia, meaning that their heart itself is not getting enough blood and their heart's kind of like it needs more blood. If the patient has chest pain, shortness of breath, reduced exercise capacity, and or EKG changes, as well as a lack of response to medical therapy. So you can just transfuse them, you can give them blood if they have issues. And that's basically that on anemia of chronic disease. So it's seen a lot in patients with chronic kidney disease. That's what it was a question for nephrology, which is studies of diseases of the kidney. Alright, we are going to do anxiety because I'd like to read up on it. So, anxiety is persistent, excessive, and difficult to control worry associated with significant symptoms of motor tension, autonomic hyperactivity, and or disturbances of sleep or concentration. Systems affected pretty much include everything. The prevalence, the 12-month prevalence rate, meaning in a given year, how often will people experience anxiety? It's actually 2 to 3%. The lifetime prevalence rate of anyone in their entire life experiencing anxiety, 5%. Onset can occur any time in life, but is typically adulthood. The median age of onset in the United States is 31 years old. It predominantly is female over male with a 2-to-1 ratio. It is thought to be mediated by abnormalities of neurotransmitter systems, including serotonin, norepinephrine, as well as GABA. I love GABA. GABA is a neurotransmitter that's kind of like the neurotransmitter. It kind of calms down nerves from overreacting. It kind of suppresses them. Okay. There is a strong link to depression in heritability studies. There is a variant of the serotonin transporter gene, and it may contribute to both conditions. Other genes, like for that of glutamic acid decarboxylase, also play roles. You don't need to worry about that. Risk factors: Caucasian race, adverse life events like stress, medical illness, disability, unemployment, and childhood physical and mental abuse. Family history, lack of social support, depression, and of course, it says lesbian/bisexual women at increased risk. I would say anyone in the LGBTQ community. General prevention. Exercise. Regular exercise is associated with decreased anxiety and depression. To a certain degree, absolutely. Commonly associated conditions with this: major depressive disorder, bipolar disorder, alcohol/drug abuse, cigarette smoking in adolescence, panic disorder, agoraphobia, which is agoraphobia is a form of social anxiety, but it's only associated with specific situations in public. Simple phobia, social anxiety disorder, as well as anorexia nervosa. Okay, diagnosis is primarily made through history taking, my favorite. History and evaluation should carefully identify generalized anxiety disorder from other anxiety disorders. Symptoms of excessive anxiety and worry must occur more often than not for at least 6 months. At least 3 additional criteria are required for diagnosis in adults. Only 1 is required for children. So you must have 3 of the following as well. Restlessness or feeling keyed up or on edge. I have restless leg syndrome. That's one for me. Easily fatigued. Difficulty concentrating or mind going blank. Irritability. Muscle tension. Sleep disturbances, meaning difficulty falling or staying asleep. Difficulty controlling worry. As well as persistent worry must cause significant distress or impairment in social, occupational, or other areas of functioning. This is what we call functional impairment. What is their functional impairment? Okay. Because for something like anxiety, we're not going to ask you, rate it on a scale of 1 to 10. You know, how painful is this? You can't do that. That's for more like somatic, more like, burns or pain, things like that. So for this, we're going to ask, how is it affecting your daily life? How is it affecting your functioning? Are you struggling at work more often? Are you not getting things done that you need to? Things like that. For me, having to redo a year of school, that's one. The focus of anxiety and worry is not consistent with or limited to the occurrence of other types of psychiatric disorders and is not directly related to PTSD. So they're saying that your anxiety cannot come from another psychiatric illness if you want to be diagnosed with generalized anxiety disorder. All other causes of anxiety and worry have been eliminated. See differential diagnosis. This says that it cannot be because of any other illnesses from top to bottom: cardiovascular, respiratory, your nervous system, metabolic and hormonal, nutritional. Like, it can't be caused by something else, like a deficiency that you might need to be fixed on. And the patient may report symptoms of dyspnea or trouble breathing, palpitations, which is like if you feel like your heart is skipping a beat or pounding, diaphoresis or sweating, nausea or diarrhea, and or may experience tremor. These are signs of panic. You can have panic with anxiety. There is no specific physical findings, but patients may be noted to be irritable or patient may be noted to be irritable or easily startled. Observable finding of bitten nails, a tremor, or clammy hands may also be present. Okay. Laboratory tests must be normal. Initial tests should include thyroid stimulating hormone, or TSH. We want to make sure you don't have a low or overactive thyroid. We're going to look at CBC. Can't be due to like anemia or any other hematologic or other like infections or things like that. We're going to check a basic metabolic panel that's going to include sodium, potassium, glucose, bicarbonate, sodium, potassium, bicarb, chloride, glucose. I think that's it. There might be some others. Don't yell at me. And an EKG. We can use the GAD-2, which is a 2-question self-reporting scale. It has a 22% positive predictive rate and a 78% negative predictive value. Okay. There is some other testing. The GAD-7 has 5 additional questions. It provides more detailed information for treatment. There's also the Hamilton Anxiety Scale, as well as the Anxiety Disorders Interview Schedule 4. For treatment, assess for suicidality given increased risk. Identify and treat coexisting substance abuse and other psychiatric conditions. Medication for paroxetine, escitalopram, and sertraline, as well as some of the SNRIs are duloxetine or Cymbalta, as well as venlafaxine or Effexor. Second line treatment, and this is going to be something I'll touch base on a little bit to talk about. I was a girl in my program today who told me that she's struggling with her mental health, and so she's actually in therapy, and she's going to her doctor tomorrow to hopefully start an SSRI. And I was talking to her all about this, and I brought up Xanax, and I saw my earlier self with her, and she's like, "Oh no, I don't want to be on that." And I said, "Well, hold up. Benzodiazepines are highly effective in the short term, but less effective in the long term. Okay? So, let's say you come to my clinic and you're suffering from anxiety or depression. Great. Let's get you treated. Okay? Let's start you on therapy. I mean, that should be in here. I hope they talk about it. They don't. Okay? We'd get you on something like cognitive behavioral therapy. Something like that, okay? I can't believe they don't talk about therapy in here. Wow. I cannot believe that. Anyway, we're going to start you on therapy. We may also start you with an antidepressant right away. Okay, these medications take approximately a month to start effects. However, Lexapro is an exception that tends to take effects within 1 to 2 weeks. I noticed that specifically. So a month, that's a long time for you to not have treatment. So what we can do is, in the meantime, while you wait, we could give you as needed Xanax or Klonopin, let's say, okay? And so everyone in the comments right now, or everyone listening, is like, what? This is the thing. If you have an addictive personality, let's talk about it. Do you struggle with food, or with porn, or sex, or with substances? Do you find yourself getting addicted to those things? Then maybe we would shy away from it. People can wait the month. I waited a couple of weeks for my Lexapro, and that was fine. If you don't have an addictive personality, you're not super worried, we could give you these benzodiazepines short term in the meantime to give you some relief, okay? Because it's hard to live with anxiety and depression. It is also then used for as needed, and that is something that I struggled with because I get bad anxiety, let's say the night before an exam or the night before school starts. I couldn't sleep. So what we prescribe this for is for those situations. If you have a recital, or you have a concert, or you have a first day of school, or an exam, and you can't sleep, or you cannot function, okay? For those very, very stressful situations, we could prescribe you 30 days of Xanax or Klonopin, and even having the prescription, let's say, in your bag at school or with you at home, brings such a relief knowing I have something that if it does get to be too much, I could take this, okay? These drugs are only addictive if you use them multiple times a day for greater than 2 weeks, okay? For me, I was prescribed a 30-day supply of alprazolam or Xanax over a year ago. I have not refilled my prescription yet. I haven't needed to, okay? And my patient, they may not need to. If they needed a little bit more than that, let's figure it out. Maybe you need to, are you in therapy? Maybe you need to work on some more things in therapy. Maybe learn some more coping mechanisms. If it really is that you're just going through a breakup or going through something else, understandable, okay? If the patient is like me or like you and worried about getting addicted, odds are they will not get addicted, okay? But there are other options. Hydroxyzine, which is Atarax or Vistaril. This is a first-generation antihistamine. It's sisters to Benadryl or Unisim, which is a sleep aid. This is basically just going to sedate you. Okay, it's just like Benadryl or Unisim, like I was saying. It's a sleep aid, basically. So this is something that is kind of going to depress the central nervous system. Okay, it has a decreased risk of dependence compared to benzodiazepines. want to start Xanax when I first started my antidepressant. When I switched over, I mean, obviously I could tell a difference. A benzodiazepine versus an antihistamine, big change. So, really think about it. Think about the stigma associated with it. Obviously, people are overprescribing it. Xanax, Klonopin should never, do you hear me? Never be your only treatment for anything. Never. 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 You should always have other medications. This is an as-needed medication, okay? Used in the short term, infrequently. If you're ever told otherwise, come and talk to me, okay? Now, there's some other options for if an SSRI or an SNRI doesn't work, okay? Buspirone or Buspar, okay? This is another drug. These are what we call our atypical antidepressants. Another one is quetiapine or Seroquel. This is a second-generation antipsychotic. It is efficacious, but it has more side effects than an SSRI or SNRI. Another option is pregabalin or Lyrica, okay? This has been shown to decrease anxiety scores and prevent relapse, and it also may cause less sexual dysfunction and sleep disruption than SSRIs. And let's talk about that. That kind of brings us into, do they talk about that? I guess not. Do they talk about drugs in here? It'd be nice. Okay, so we can just talk about it. I don't need a textbook to talk about it. This is what I like to do for fun. Okay, so SSRIs, my best friends, they have a couple common side effects, okay? One of them being sleep disturbances. If you take it at night, you may have trouble sleeping. We can transition you to a morning dose. I did that myself on my own. Worked great. Another common side effect is possible weight gain. Now, people hear this and they're like, oh, I don't want to take it. I associate this with more of your patients who we were talking about anxiety. Maybe it's a patient with, we were talking about bulimia. I think we were talking about bulimia or anorexia nervosa, okay? There's obviously treatments for that. Therapy's great. Maybe this ends up helping with the depression and the anxiety and maybe some, underlying eating disorders that you may not know about. And it makes you get your appetite back. That is possibly what the side effect comes from, okay? I've been on my SSRI for 2 years now. I've gained weight, but I've also been through a breakup. But guess what? I've been working out and, getting the weight off. No big deal, okay? You also have to remember, and we've definitely talked about this before, but I have no problem talking about it again. With any sort of drug trial, any single symptom a patient experiences, it needs to be recorded, and then it goes through an independent scientist / medical professional decides if it's possibly, probably, or definitely related to the drug. Okay? That doesn't sound too super accurate and based on the science to me. Does it to you? No. So you're going to hear a lot of side effects associated with drugs that may not happen because they are just anything under the sun that the patients experienced. Some other ones, sexual dysfunction. For men, trouble with libido, okay? Trouble with maintaining or achieving an erection or with having an orgasm or ejaculating. Completely normal, okay? Some people like it, some people absolutely hate it. It is temporary. It comes and goes in waves. It is something that I feel, but we could talk about it as a provider and as a patient. If this is something that's really affecting your relationship or your love life, we can talk about other options. There's other options. We can figure it out. But in my case, as a patient who's on an SSRI, it's well worth it. My mental health is way more important than sex, okay? And I remember talking about this with my provider only I think maybe a month or so, or two, maybe after starting mine, when I started experiencing them and I was dating this boy. I said to her, I had trouble ejaculating with this boy, and then I reminded myself, that's not as important as my mental health. I'd rather stay alive than ejaculate. orgasm as well. Again, if it's an issue, let's talk about it. It's not the end of the world. It is reversible, and there are other options out there. So, that's that on that. We have time for one more small. They have juvenile idiopathic arthritis. Ain't that funny? But they don't have. Oh, here's all the arthritises. Baby. Let's do it. Rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic autoimmune inflammatory disease with symmetric, meaning same on both sides, polyarthritis, meaning multiple joints are inflamed, and synovitis, synovium. The synovium surrounds the joint. So let's say we're talking about this joint here. There is a surrounding synovium which has fluid in there, a little bit of fluid that can be inflamed too. It's also associated with progressive chronic inflammation that leads to large and small joint destruction, deformity, decline in functional status, as well as premature morbidity and mortality. Okay? The incidence is 25 to 30 in every 100,000 males and 50 to 60 of every 100,000 females. So it's more females than males. The peak age is 35 to 50 years old, and the U.S. population prevalence is 1%. So this is an autoimmune disease. Autoimmune, we theorize and we kind of know, are most typically started by some sort of insult, we call it. Whether that be an infection, whether that be a trauma, something causes our body to have a response. And in turn, during that time, becomes overstimulated and over anxious about things. So it gets on the defensive, and next thing you know, your body is attacking itself. Okay? This is a multifactorial disease with genetic, hormonal, immunologic, as well as environmental factors. Okay? There's a genetic link because twins, it's seen in 15 to 20% of twins, suggesting there's genetic as well as non-genetic effects. First-degree relatives have a 2 to 3 times increased risk. Smokers have a 1.4 to 2.2 fold risk, and pregnancy and breastfeeding for 24 months lowers your risk. Interesting. Okay, these are some constitutional symptoms, meaning just very general symptoms. Fatigue or tiredness, malaise, again, tiredness, weight loss, low-grade fevers, that could be anything. Articular symptoms, meaning about your joints, you may have tender, swollen joints. Early morning stiffness, we call this AM gel, okay? This is at least 60 minutes, and as well as a difficulty with activities of daily living. But most time with patients with rheumatoid arthritis, you have that long, early morning stiffness, but activity really helps it. So if you get up and you start moving, that stiffness will go away. Some extra-articular involvements, meaning outside of joints, some other involvements. It affects the skin, the lungs, the heart, the eyes. The onset of this disease is typically insidious, meaning slow, and you don't realize it until later on. Patients rarely present with abrupt onset of symptoms. Okay, so there is some physical exam. We got to look at your joints and things. We're gonna get some tests. We're gonna get a CBC, to look to see if you have an anemia or any changes in platelets. We're gonna get something called an erythrocyte sedimentation rate, as well as a C-reactive protein. These are both markers of inflammation. If they're elevated, it doesn't tell us what is inflamed, but it's telling us something in your body is really inflamed if it's elevated. And the most specific thing for rheumatoid arthritis is anticyclic citrulinated peptide antibodies, or anti-CCP. If you have elevated those, it's pretty much you're saying you have rheumatoid arthritis. As well as anti-nuclear antibodies. This is an antibody showing that you have some sort of autoimmune. If it's positive, it's basically saying you have some autoimmune in you. We're going to check, disease-modifying anti-rheumatic drugs, and for short we call them DMARDs, okay? They are the number one choice, okay? These drugs are great. Now we have what's called our synthetic DMARDs, and we have biologic DMARDs. Biologic are where we take like antibodies and use them. Okay, kind of like that RoGam earlier. You're going to use antibodies against antibodies and things like that. Synthetic are more like chemical things. Okay. These DMARDs should be started within 3 months of making the diagnosis of rheumatoid arthritis. Due to their greater convenience, lower toxicity profiles, and quicker onset of action, initial therapy is usually the synthetic DMARDs like methotrexate, sulfasalazine, and leflunomide. They have comparable efficacy. Okay, methotrexate or Rheumatoid. This is a weekly dosing. You know, it can be anything from 1 weekly pill to 7, or even more, I think. It's the most predictable benefit. It has many significant side effects. If you take methotrexate, you need to be on a folate supplement of 1 milligram per day. Okay. You cannot drink alcohol if on it. You need to have your CBC monitored every 3 months, as well as a bunch of other things. Basically, you have to get pretty much a lot of things monitored every 3 months. Okay. We are going to start you off on a 3 to 6 months trial with this medication to see if you have effects. Okay. It is contraindicated, meaning it cannot be used in patients with renal and liver diseases, pregnancy, or breastfeeding. Okay. Then we have the biologics, as we were talking about. If you do similar, this is a great analogy. Okay. These take months to take effects. Months, sometimes 6 weeks to, I think our PA today said sometimes even months, like long, like months to take effect. You're going to be suffering in that meantime. So similarly to an SSRI taking its effect and us giving you Xanax or Klonopin in the meantime, we're going to give you a DMARD and we're going to give you a steroid in the meantime. This is not something we want to use long term, but in the meantime, while it takes effect, we're going to give you a steroid either orally, or we can give them injections or intra-articular, like into the joint. Yeah, that's pretty much rheumatoid arthritis. There's a lot of, it affects a lot of different things. This is